Hello, everyone. Thank you for joining today's webinar. So we're waiting for a few more people to join. I will be starting in a couple of minutes. Great. So thank everyone for joining today. Today we will be listening to the topic of engaging private providers in rural healthcare. Before we move on with the topic, just a few logistical announcements. This is going to be a 1 hour webinar. We will be also live streaming on YouTube, and the recording of this webinar will be available on the TBPPM YouTube channel. We will also be preparing a report that will be available in the next couple of weeks. We request you to have your questions posted in the Q&A section of the webinar. You can see that at the bottom of the webinar, and bottom of the Zoom page, you can post your questions, and the panelists will be answering the questions on the Q&A. And towards the end, we will have some time for discussion where we will be taking some questions as well. So if you would like to speak during the discussion section, please raise your hands up and using the Zoom function, and our moderator will call on you. So today we have a very fantastic panel, as you can see, from across the world. We have with us Dr. Poshan Thapa, who's the postdoctoral fellow at McGill TB Center. He has vast experience in informal providers and is currently focusing on strengthening capacity for informal providers in TB care. He will be giving us an introduction on the topic, and then we will hear from Mahfuza Rifat from Bangladesh. She is the country representative for Damien Foundation, which supports the TB program in Bangladesh, and she has a wide range of expertise in drug-resistant TB, and she's also an health specialist with experience in health system and health financing. Next, we will be hearing from Dr. Saminu, who is from the Leprosy Mission at Nigeria. He has gained vast experience in TB and HIV services. He has over 10 years of public health experience, focusing on effective collaborative approaches and strengthening health systems and community empowerment. Then we will hear a combined presentation by Rajabao and Shankar. Rajabao is an health professional who's been working in Maharashtra, and Shankar has been the project lead of the PPSA projects in Jharkhand and Maharashtra. And finally, we will have the Q&A moderated by Aji, our dear colleague Aji, who's also a public health professional and the community manager of TBPPM Nigeria chapter. All of their bios, all of the panelists today are members of the TBPPM Learning Network, or will be the members of the TBPPM Learning Network. So you can find their bios and access more details about them through our website. So without further ado, I'm happy to introduce Poshan to introduce the topic and introduce the first speaker as well. Over to you, Poshan.
Thanks, Joel. Hi, everyone. My name is Poshan Thapa, and I'm a current postdoctoral fellow at McGill University. So there are countless reasons why we need to focus on rural TB care. And to mention some, a large proportion of population still live in rural areas in many low and middle income, especially in low and middle income countries where TB continues to be a significant problem. And as we know that in rural areas, the access to care is limited, resulting in delayed TB diagnosis and treatment. And also the stigma that exists in the communities and the low level of TB care knowledge and awareness in the community, as well as most importantly, in rural areas, people seek care from a mix of providers, especially in case of tuberculosis. When patients have initial symptoms, they don't go to a specialist. They go to a primary care provider who is very close to their home. So in that case, it could be a formal or an informal healthcare providers. So in case of rural TB care, there has to be a comprehensive approach, as well as all the providers, both formal and informal, have to be engaged within the framework of public-private mix. Since I have worked largely with the informal sectors, I will give a brief uh, outline of what I do, just to give a context to highlight the importance of informal healthcare providers in TB care. This picture may be familiar to many of you, either personally seeking care from informal healthcare providers, or hearing stories of people seeking care from informal providers, or your experience of informal provider existence in the health system and the providing primary care. So I do most of my work in India, so I bring the context and data from India, but this is applicable to many low and middle income countries. First thing is like, since informal providers are not prioritized in the health system overall, plus there is no national level data, but there exists the documentation of two small scale surveys in India where which reports the existence of informal providers in a health system ranging from 41 to 67%. And in some contexts, they outnumber the qualified doctors as well. And these data are supported by the WHO's India's Health Workforce Report as well. So the most important thing is that very high visible reporting in TB care. So in a systematic review has shown that 9 to 90% of primary care in LMICs is delivered by IPs. And in case of India, especially in rural and underserved areas, they provide up to 70% of primary care. The reason why, the thing I want to highlight here is primary care is very important in TB care because, as I said, when people have initial symptoms of cough and cold, they don't go to a specialist. They go to a provider who is just next door and is available at any time. So these usually, for many contexts, are informal healthcare providers. And in case of first contact in TB is very important because you want to capture patient during the first visit to a primary care provider for various reasons, for early diagnosis and treatment, as well as to prevent further transmission in the community. And there are some of the reasons why it is important to engage with informal healthcare providers. As I said, they are the primary care providers. Studies have shown that in India, for 10 to 59% of TB patients, they are the first or the preferred providers in the community. And there's enough literature which says that seeking care from informal providers results in delayed TB diagnosis and treatment. An important reason why this kind of health workforce needs to be integrated in national TB programs. And through our research plus existing research, there is enough to document that informal providers do provide TB care services in the community, either in the initial consultation or to prescribe antibiotics for the symptoms of cough and cold, and in some cases, even the TB medications. And all of these in the context, we also did another study to see if they have enough knowledge to deliver TB care, and we found that IPs have suboptimal TB level of TB care knowledge. So with these all in context and their existence in the health system and they be primary provider, it is very crucial that they are the prioritized group in national TB programs. But that's not the case. There are very few examples where they have been engaged, but they lack a systematic engagement in formal TB care programs as compared to the other formal private providers. And this is one of the diagram. I'm not going to go into detail because I don't have enough time, but this is recently published in BMJ Global Health, where we have identified different roles that IP can undertake in alignment with the WHO standard for TB care, and what are the building blocks that needs to be taken into account in order to for the successful engagement. I'm happy to take questions at the end, but because of limited time, I would like to pass it to my friend Mahfouza Rifat for her presentation. Thank you, and over to you, Mahfouza.
Thank you very much. Thank you for the session and very interesting session, my former colleague. So I would like to use the presentation to share our experience from Bangladesh. I will also speak about the engaging the informal provider in a systematic way in Bangladesh. So we all know that Bangladesh is a WHO-defined high burden country with a very high prevalence.
Officer, sorry to interrupt. Could you change it to the presentation mode, please?
Sure.
Yeah. Okay, this on the display settings on the top.
Sorry.
We still see it
Yeah.
as a presenter mode. Yeah. Yeah. Yes. Perfect. Yeah.
Okay. So just the background for Bangladesh, it's a high-burden country for TB, including the DRTB. And for example, in 2022, we had 0.26 million people affected who received treatment from the National TB Control Program. In Bangladesh, there is a complex health care sector, including a large presence of private healthcare sector in urban and rural area. And also, definitely, there are formal sectors and informal sectors, including private hospital, and so it ranges from the unqualified providers to a very high scale tertiary and high specialized hospitals. And with NTP, there are many other partners like Demen Foundation. So we are engaged in TB control through a formal memorandum of understanding. So we are providing large-scale TB services in TB for decades in Bangladesh. Why informal providers? Because there is a very good health system, health structure, I would say, through the government, starting from the national level to the peripheral level. However, despite this availability, people prefers to visit the informal providers, as my previous speaker already also mentioned in the other context. Because of the proximity and also due to the affordability and accessibility with these providers, especially the drug shop retailers are the first contact of many patients for their primary level care. And 75% of the rural population depend on small informal service providers. Most of them have no such professional trainings. So we acknowledge this situation and the widespread utilization of informal providers. They're commonly known as village doctors due to their proximity and affordability. They are mainly the drug sellers in a drug shop, but they may have or may not have some kind of training or in health. Sometimes they're semi-qualified and sometimes they're just drug sellers in a drug shop. They are, as I've already mentioned, they're the first contact. People prefers to go to them for their preliminary symptoms. And so Demen Foundation Bangladesh, we established a network of these informal providers so that they can provide a patient-friendly services to the community. And this is mainly the voluntary involvement, and they are commonly known as village doctors. But we also engage cured patients, some local elites like religious leaders, school teachers. Additionally, also we not only the village doctor curative patients, definitely we also did formal linkage with the private the qualified private sectors, the graduate practitioners. But this is not I keep my presentation up to the informal providers for today because we did a formal linkage with these village doctors in Bangladesh. So we call them the fixed dose providers because at least 10,000 this type of informal providers are engaged with Demen Foundation. Due to the close proximity and the community, they positioned this model well to detect TB symptoms and monitor the treatment once they're diagnosed as a TB patients. And they also refer TB presumptive for diagnostic centers, for gene experts, or for especially to the health centers. And once diagnosed, they are acting as a local treatment supporter. So patients do not have to travel long to the health centers or to the next level. They're very close to their house. They can get their daily medicine there. And also they feel comfortable. And this approach has been recognized as a large rural PPM approach by WHO. So the interventions are mainly we train them on basic messages of TB. And also train them how to provide monitor the treatment, what are the common medicines and how to monitor that. We also train them with some, irrational use of other medicines for TB presumptive, so that sometimes there is a practice that they can give, if someone has a cough, and give any antibiotic. So we train them on these practices as well. So they refer TB presumptive for diagnosis. I think there's a repetition, sorry for that. And so this is the main thing. We train it's not a long training, like a one-day training. We start this, but we keep following them up and we keep them engaging throughout the process. So we do not provide any financial incentive, but it's mostly non-financial, and they only get some financial benefit during their training time. And so they get updated information, and also the linkage with the health providers, like the doctors, like the government formal system. They established only the Demin Foundation Hospital and Demin Foundation staff. So they established this linkage. And also they make a good network with the cured TB patients in the community. They support each other. But the main motivation, they consider that it is their opportunity to high quality TB care, and that they're getting the very high quality drugs on their hand. And so it's a trust, a local level trust from the society that really motivates them. They make them interested. Also, they consider it's a moral responsibility to the society and for the respect, social prestige, and indirectly that increases their client, not TB, maybe non-TB patients. And we also have a system of regular supervision by our staff, because whether how it's going. So during the visit, our staff also checks the patient cards, drugs, stocks, and provide them with short-term drugs, short duration drug treatment as well, and also motivate them to keep up the work. So this is a referral slide, like in 2023. It's a 3.5%, usually like 3 to 5% are referred by the village doctors or informal providers, but there are other, some cured TB patients are also there. They also refer 2 to 3% of the patients. It's not the patients, after sending the patients, when we have all the TB patients, and we just analyze from which referral source they are coming from. But if we look at the presumptive, it is sometimes even higher. This is the trend of Demin Foundation area. We are treating, in 2023, we treated 40,000 patients, 40,000 plus patients, TB, all kind of TB patients. And if you look at another picture, like who were providing the supervised treatment or DOT in that time, actually 43% were provided by these village doctors out of that 40,000 patients. And also we have other community members like cured TB patients as well, and also some responsible local community allies who are supporting it. And in Bangladesh, actually, we have a very good cure rate for drug-sensitive TB patients. That is mainly for the community level engagement here. I will stop here, and if you have any question, and I will pass my to the next presenter, if not. So thank you very much.
Thank you, Mufasa. And our next presenter is Saminu from Nigeria. We'll be hearing about the informal providers from Nigeria. Mufasa, could you stop sharing the screen? Great, thank you.
So thank you so much, Mafuja, for that very insightful presentation. There's definitely a lot to learn. So I'll hand over now to Dr. Saminu to give us his own presentation on rural TB care in Nigeria. Go ahead, Dr. Saminu.
Good afternoon, everyone. I believe I'm audible. Greetings from everyone here at my office. Many thanks also to everyone that made this happen. Many thanks to Azi and everyone at TBPPM Learning Network. I'll be taking just very few slides here. My presentation would focus on rural TB care, engagements, and other aspects as shared by the organizers, particularly in northern Nigeria. I'll be presenting using this already shared outline. Of course, I'm not here alone. My colleagues, I can see them, they've joined in the participant list because this is a result of our work in the past 5 years, ever since we started implementing the Global Fund PPM project here in Nigeria. TLMN is an organization I work for. I work in TLMN as a medical advisor. We work across various states in Nigeria, as you can see on the map there. TLMN is a household name in Nigeria when it comes to TB and leprosy control. Of course, it's a leprosy-focused organization. Looking at the PPM aspects of our work, we implemented secondary recipients to the Global Fund project. Institute for Human Virology, IHVN, were the PR for this project. We implemented in 7 states: Sokoto, Zamfara, Kebbi, Niger, Kogi, Nasarawa, and Jigawa states. For those that are conversant with Nigeria, these states are in the north central and north western states of Nigeria. Of course, the north is comprises of 19 local governments, which has similar socio-demographic conditions, similar culture, especially for those that reside in the rural area. This is our mandate. This slide will be made available so that people can get access to some of these things. For the projects that we ran, the Global Fund GC6, Grand Cycle 6 project, we had targets and goals. PPM coverage in 2017, just when this project was about to start, was at 2.5%, and we had a target to raise it to 31% of the total cases contributed from the country. We had increase, part of our objectives was to increase coverage of faith-based organizations and PFPs, and to increase notification of TB across the country. Stakeholder engagement in rural settings is not something that is very easy. It's something that is done mostly in the grassroots. Being a grassroots activity, the key person involved there is the linkage coordinator. Various presenters on this platform, I've had them mentioning linkage coordinators in their presentations. It's just an individual that ensures linkages are done between hub and spoke facilities, someone with a basic literacy level. This linkage coordinator has up to 5 hub facilities that are under his purview, and each of these hub is mapped to 10 spokes. Of course, the hub and spoke model is what we are using for this PPM engagement in the rural sector in Nigeria, where the hubs are where diagnosis and treatments of TB takes place, and these are linked or mapped rather with various spoke facilities. These are the various hub facilities we have in rural settings in Nigeria. We have the private for-profit facilities, and of course the faith-based organizations. The spoke facility types include the patent medicine vendors, community pharmacies, and most importantly at the rural setting, the traditional birth attendants and traditional healers. In Nigeria, up to 60% of people first seek health care in the private setting, which is depicted in these hub and spokes that I've outlined. We also have pseudo hubs in some of these rural areas that we implemented in the past 5 years. These are where there are no private PFPs, no private hospitals, and no faith-based facilities. So in these situations, we use the patent medicine vendors to stand in as the hub facilities where diagnosis and treatments take place. So in these communities where there are no hospitals, we don't just want to leave TB to be thriving there, but of course we can use the pseudo hubs. These facilities are owned by trained DOT officers engaged in the public sector. So they have an understanding of TB, they have some basic medical qualification, they are literate, and they are literate individuals, and of course these facilities have some space, not just a very small shop, but like a PMV that has some space because of where we can keep the drugs and other recording and reporting tools. This is just to showcase what we did in the last year, 2023, where we had up to 99,324 cases reported from this states, and of course 44% was yielded from the PPM project. That is totaling 43,423 TB cases from these 7 states that we that we were supporting. This ranged from percentage contribution ranged from 18% in Kogi State to as high as 63% in Sokoto State. So this is just to show that we have a good number of cases from our project that we implemented that ended on 31st December last year. Most of our cases are from patent medicine vendors, about 56%. This is followed by cases that were yielded from FBUs and the PFPs, which is 31%. The TBAs yielded 12%, and we had the least contribution from community pharmacies, just 446 cases, which is 1% from the community pharmacies. All this is not without challenges. As a background, Nigeria, most of our population reside in urban areas, but 46.48% reside in the rural setting. Most TB cases in northern Nigeria are from the rural communities. From our findings, Nigeria has an incidence of TB, incidence rate of 219 per 100,000 population. This project that we implemented of some incentive, and we pay incentives on a monthly basis for us to achieve, to have a build that we had. The main underlying obstacles to prompt diagnosis and treatment of TB among individuals living in rural areas include poverty, physical topography, far distances to these facilities, and also restricted access to healthcare services. Furthermore, the combination of these structural obstacles and socioeconomic factors like malnutrition raises the risks of tuberculosis deaths and follow-up loss in patients living in rural areas. The care pathway is more convoluted for those living in rural areas who also tend to know less about tuberculosis and exhibit greater stigma and dread of this illness. There are a number of obstacles to overcome when using private providers in Nigeria's rural TB care programs, but they are also workable answers. Looking at some of the challenges we have, number one is lack of awareness. You see a facility, a PPMV, they have limited awareness about TB and its symptoms and the importance of early detection and treatment. This is very common in the rural setting. Diagnostic facilities are centered mostly in the urban centers. Hence, samples for TB diagnosis have to be transported for longer distances to the urban centers where we have gene expert diagnostic sites, TB lab, even chest x-rays. One thing I've noticed in most of these states we supported on the project that just concluded in December, some x-ray machines are not found, particularly in the rural areas. Most times you see x-ray machines only situated in the capitals of the states. Hence, children and other people you would want to, other patients you would want to diagnose using x-ray have to be transported to the capitals, and this can be a little bit difficult. Stigma and discrimination around TB is still something we find common in Nigeria, especially in the rural areas. Some of these engaged facilities kind of have that fear of being associated with this disease. Financial constraint is something else that plays a role in what we do. Even though we pay incentives, some of these incentives are not adequate. Hence, there's a financial barrier to providing TB care. Fragmented healthcare system. In many rural areas, healthcare facilities are fragmented with limited coordination between public and private providers, leading to gaps in TB care. Looking at some of the innovations we've had in the past years on implementing this Global Fund project, we have been training and retraining. One key issue with PPM that has been identified even on this platform on previous webinars is a high rate of attrition. People in the private sector move on to greener pastures, they move on to build up their capacity, schooling and other things. So after training some of them, they leave the facility. So there's a need to train, retrain, and after training, this training should be cascaded to other staff in the facilities. Diagnostic support, offering subsidized and free diagnostic tools, everything about TB, diagnosis and management in Nigeria and in many parts of the world is completely free. So these diagnostic tools can be provided to TB private providers such as TB Lab in Sokoto State and in some of the states we support. There are even gene expert sites that have been placed in some of these private facilities in rural areas. This is to limit and reduce the travel time for people and taking samples to the urban areas. Community awareness campaign, implementing community-based awareness campaigns to reduce stigma and increase knowledge about TB can encourage private providers to actively engage in TB care without fear or social repercussions. Financial incentives, as I've mentioned, this project is incentive driven. When you pay them, they do more for our TB patients. They even go out, of their way to look for TB cases in the communities. Strengthening public-private partnerships, establishing and strengthening partnerships between government, health agencies, and private providers can facilitate collaboration, improve coordination of TB care, and leverage resources to strengthen TB control efforts in rural areas. Something that is coming up strongly for TLMN and in these states we support is telemedicine and mobile health. We have a mobile clinic that we use in some of our states, where this mobile clinic, which is manned by trained TB care experts, goes into some of these communities, providing care to these communities. Furthermore, these are some of the challenges specific to our work. Attrition, I've mentioned it. We have an app called MATS app, which is an Android-enabled screening app, weekly tracking, which we use for screening. The usage across these 7 states we supported in northern Nigeria has been low. It's not far from the fact that people are shy away from using technology for work, and also some of the phones that they were given, the battery life and all that doesn't last so long. So MATAP has been an issue for us. Insecurity is something we cannot have this presentation not for neither Nigeria without talking about. Most of our states have been taken over by banditry, insurgency and all that. So most people are now leaving the rural areas and moving to the urban area. Urbanization is something that is fast happening in Nigeria. Low DRTB case finding, we mitigate this by 100% contact tracing of all diagnosed DRTB patients. We prioritize and optimize gene experts testing for almost all our TB cases. HIV screening, we want to screen every presumptive TB case for HIV. This is not always possible because these RTKs are not just available in the private facilities, especially those situated in the rural area. So we have to, something we've done to resolve this is to map these facilities to public sectors, public facilities in these rural areas. Lastly, there's a lot of discrepancy between our data with that reported by the state TB programs to the national TB program. We escalate this as soon as we notice this, and we now have monthly harmonization meetings between our linkage coordinators and the local government supervisors at the local government level. In conclusion, the hub and spoke system of implementation has significantly strengthened community referrals of TB presumptive and linkage to treatment of diagnosed cases across northern Nigeria and, of course, in the rural setting. Data reconciliation at LGA level is key to reporting quality PPM data at the state and at TLM level. The pseudo-hub system, operational in Sokoto State, Niger State, even in Kaduna State, where we have PPMVs being sites for TB diagnosis and treatment, has also given us a high yield of TB cases from these pseudo-hub facilities. This is our mobile clinic. You can see visit to one of the communities where we got from this very community. In just one day, we had about 58 cases of TB diagnosed in that very day. Thank you. These are community awareness campaigns. You can see me there with the pickup with my laptop. These are also community awareness campaigns carried out in Sokoto State. Thank you very much. And over to you. Thank you.
All right. Thank you, Dr. Saminu. That was a very interesting presentation and very insightful as well. I note a lot of similarities between your presentation and the previous one across Nigeria and Bangladesh. So that's very interesting to note. There's also many differences, certainly enough for us to learn from one another. So yeah, so I look forward to the next presentation. I want to call on, this is a joint presentation from India. So I want to call on Rajabao and Shankar, who will be talking on TB Free Village Initiative in India. Please go ahead.
Yeah, so namaskar and good evening to all from India. So hope my presentation and my voice is audible. Yeah.
Yes, we can hear you loud and clear.
Yes. So I'll be talking about what is going on in India about TB-free village initiatives, specifically in Maharashtra, and Dr. Shankar will take over further. So all of us are aware that India contributes almost more than 1/4 of global TB burden. And to measure this burden, India has different strategies like I think my slides are not moving.
Maybe you can reshare.
Okay. Yeah, now it has maybe some internet connectivity was there. So India is have planned already. India has given commitment to global community that India will achieve SDG targets of 2030, 5 years ahead, that is by 2025. So to measure these achievements, country have different plans, like we have already initiated district level subnational certification, so that how many districts are having decline in incidence. So in the continuation of that, India has launched the TB Mukt or TB Free Panchayat initiative on 24th March 2023 to measure how many villages or gram panchayats are becoming TB free. So just for your understandings, panchayat comprises of one or more villages depending on the population of that village. So what is this initiative basically? It is to leverage the support of over 0.25 million gram panchayats which are there in India. And we are trying to raise the awareness about TB among rural population, because still in India, majority of population lives in a rural area, almost more than 60%. So reaching to them is very important. Again, this strategy will help to eliminate the stigma attached to the disease, and will monitor the progress, and maybe this initiative will help to raise the or demand the services for TB from the rural area. So basically, what are the objective of this TB-free villages or TB-free Gram Panchayat? So it is to empower the Panchayat Raj institutions to realize the extent of problems associated with TB, take necessary actions towards solving them. Because Panchayat is the last government institution in India, and we have elected representative at that level, village level. So increasing their ownership related to TB is very important, and then we can take it further. Again, this will create a healthy competition among these villages, and we can appreciate their contributions. And it will increase the accountability of panchayats along with the community institutions. So they can take the ownership of their patients, they can sensitize, they can mobilize the resources for the TB patients who are taking care in their villages. So that's why this initiative is very important, and it will definitely in long term increase the awareness among the people, and they will start demanding the services for them, and it will help in reducing the stigma also. So how we are going to measure these TB-free initiatives? There are certain indicators devised, and this activity is actually started from last year. And this evaluation we have completed recently by March. So these are 6 indicators on which NTP program is going to assess whether this village is TB-free or not. So first indicator is number of presumptive TB examination per 1,000 population, and it requirement is more than 30 presumptives per year in that village or panchayat. So this indicator is important to increase the presumptive examination so that we can screen the majority of the population and make sure that there are no more TB cases in that village. Second indicator is TB notification rate per 1,000 population, that it should be less than or equal to 1 per 1,000. Treatment success rate more than 85%, drug susceptibility testing rate 60%, then Nikshay Poshan Yojana 100%, and under Pradhan Mantri TB Mukta Bharat Abhiyan, Nikshay Mitra support, providing nutrition to these patients should be 100%. So basically the first 2 indicators are, first indicator is a process indicator, and the remaining indicators are related to providing the services to TB patients in that villages. And our ultimate aim is to have a more screening for TB, and whatever TB cases are found in that villages, they should be owned by local peoples, and their treatment outcome should be good. So that kind of monitoring is going to happen through these initiatives. What are the steps followed to declare a Gram Panchayat as a TB free? So every year in January, month of January, they will have meetings of panchayats. Then they will prepare the data or in whatever indicators set. Based on that, they will assess whether their Gram Panchayat is fitting into submitting the claims for TB free Gram Panchayat or not. Then district level teams will validate their claim, whether those indicators are fitting properly or not. And then there will be validation of those 6 indicators. And if all those 6 indicators are achieved, then they will be given a TB Mukta Panchayat certificate along with the statue of Mahatma Gandhi. In first year, the statue will be in a bronze. Then they continue TB free status in second year. Then they will be given a silver statue, and if they continue TB free status for 3 years, then it will be given as a golden statue. So what is the current status in Maharashtra about this TB free Gram Panchayat initiative? Because this was the first year. So in Maharashtra, we have total 27,850 Gram Panchayats. So out of these Gram Panchayats, 2,485 submitted their claim for TB free based on those 6 indicators. So that was almost 9%. And out of these Gram Panchayats, almost 2,249 declared as a TB free because they have achieved all those indicators. So this way we are going to measure the progress, and it's not only TB free status, but it is going to increase the access of services in the village, and people will start owning the TB patients of their villages, and that will help in reducing the stigma in future. So thanks. That's all from my side. I will hand over to Dr. Shankar.
Yeah, so as mentioned by Dr. Raja Bose, this is a kind of a very intensified efforts undertaken by Government of India. As we all know, there is a lot of rural population, almost 60% people in India live in rural areas. And panchayats, gram panchayats are the lowest administrative units in the government, and they have decided to target those gram panchayats systematically and eliminate tuberculosis from that 60% population, along with definitely having urban interventions as well. So taking account of TB Mukta Panchayat initiative, so we through USAID Trust came forward to support NTP in 1000 TB Mukta Panchayat initiative. So this is a kind of a demonstration study, we can say, and what activities we need to undertake to really make those gram panchayats as a TB Mukta gram panchayat certified as a TB Mukta gram panchayat, or achieve those indicators which are mentioned so that they can get that certification. Next slide, please. But should I share it, Dr. Rajabha?
Yeah, maybe because some issues there. I'll stop my sharing.
I hope it's visible to all.
Yes, we can.
Yes, it's visible.
Yes, we can see. Yeah.
Right. So the aim is to support NTP in TB Mukta Panchayat initiative through filling by filling the gaps in service delivery. Objectives are awareness generation among households and communities, then early case finding through active and systematic screening. Then linkages for a strong TB surveillance, diagnostic and treatment services. Innovative approach for adherence to treatment prophylaxis. And multi-sectoral collaboration in terms of owning the TB Mukta Panchayat initiative by the Gram Panchayat or different stakeholders in the villages, including private providers or informal providers, which are more permanently available in the rural areas in India as well. So these stakeholders are kind of involved or engaged in all different activities we have been undertaking. We are building the capacity to let them know that what is the exact TB problem in their area and what interventions or what actions they need to undertake to make themselves or their village as a TB Mukta village or TB free village. And ultimately to build the ownership of those gram panchayats, those communities or even private providers towards their role in TB free village initiative. So methodology is threefold. One is ACSM, advocacy, communication, social mobilization. So building panchayat and community ownership. Second is awareness come active case finding by house-to-house visits in the rural areas and linkages for services. So once screened, then the people will be linked in TB care cascade subsequently. Building panchayat and community ownership, engagement with the panchayat by establishing panchayat task force for TB elimination, building the capacity on TB elimination and strategies, using IEC information, education, communication material to be disseminated in the villages for generating awareness among general population, awareness about TB through family counseling during house-to-house visits, and concept of TB champion, those TB patients who are cured or has gone through the whole TB care. They will be motivated to undertake the nodal person's role for that village for addressing any TB service related need of the community. And then Sarpanch's alliance will be established. Sarpanch is the head of the panchayat, gram panchayat, the lowest or like a local self-government system what we have in India. And we will establish the Sarpanch alliance, and then through them we will be generating the demands for TB service delivery, or might be this is redressal mechanism for any grievances about the services. So capacity building, we had a cascade of trainings at state level, then district level, and at a block level, we can call as at a village level, where all important stakeholders being trained on this TB Panchayat initiative and what their roles to be. And all the activities are kind of carried through their own initiative or through their plannings. So the panchayat members, we had advocacy meeting with them, and then through that we have established a TB Panchayat task force for that Gram Panchayat, and awareness has been generated through house-to-house visits. So we'll be going for a screening for TB in the households, and using that opportunity of having a direct contact with the household members. At least initial 5 to 10 minutes are spent on generating tuberculosis awareness or discussing, so that the kind of stigma with what is there that can be reduced, and then people can come forward for the screening. So screening for TB through active case finding, we know that National TB Prevalence Survey of India, which was conducted in 2019 to 21. There are many cases where we missed if we have used only symptom as a screening tool. So we are going more aggressive and using multiple tools along with symptom screening for active case finding campaigns. So at community level, we are kind of using symptoms, cough sound AI. So AI-based application where a cough sound will be assessed for any presumptive TB identification and past or family history of TB or comorbidities. So once that screening is done at a community level, anybody who's skin positive, they will be offered at a chest X-ray at a village level itself. So there will be one hub established where a mobile chest X-ray unit will be there. And all those screen positive at community level screening are offered chest X-ray. And then those which are positive on chest X-ray for history of TB on chest X-ray, the specimen will be collected, is been collected and transported to NAT lab for confirmatory diagnosis. So that's the TB screening algorithm. So these are some of the project staff or community volunteers doing systemic screening at household level and at the hub center. So not only TB, but we are kind of providing taking this opportunity. We are kind of addressing other diseases like diabetes, hypertension, BMI, and even anemia. So we are going with this for 5 disease screening project, and that is some way helping us to address the stigma for TB as well, and people are more participatory to get themselves assessed for TB as well. Linkages, so once a screen positive, then diagnostic linkages will be are being provided. So specimen is collected there only. Those which are X-ray machines are also equipped with the AI, and we get the at least TB suggestive results there itself, and those are again verified through radiologists. So once X-ray AI are suggested that it's a presumptive TB case, then specimens are collected, and those specimens are immediately within same day transported to NAT diagnostic facility linked with that Gram Panchayat. And once the results are available, those TB positives are started on treatment in coordination with the NTP through the community health clinics which are there in the village or Gram Panchayat level. And the nodal person, mostly the TB champions, working as a treatment supporters for those TB patients. And subsequently, they link those patients with the social support schemes as well. The next position or if any family requires to be supported for nutritional needs, then Gram Panchayat takes care of that support. So these are some of the pictures of specimen collection and X-ray been done at village level. Yeah, these are some of the feedbacks from the heads of the Gram Panchayats, the Sarpanches. Actually, both Sarpanches are female here. And they were very actively involved and very happy with the systemic approach the program has taken for the screening of their village population for TB, not only TB, but five ailments, and that helped for early diagnosis. So one village, there was no TB case for last 3 years. And through this active case finding campaign, the 4 TB cases were diagnosed. Thank you. That's from my side. So it's more towards a TB Mukta Panchayat, village level TB free or TB elimination activities. But even private sector, private providers are also actively engaged in terms of so if there is any person with a higher blood sugar level and BP high or low BP, those are immediately referred to the local providers which are available there, and they manage them further. Thank you.
Yeah, thank you so much for that presentation. I think we've had a really packed hour of just hearing how different countries and different organizations approach ensuring that people in the rural area actually have access to TB services. And a lot of the commonalities that I see across board, which is pretty encouraging, is the fact that we're all aligning to the actual realities on the field. So we're looking at exactly where people are going, exactly where you are actually finding people who have TB, and engaging the providers that are able to provide support in that area. So that's very interesting. We are now at the stage where, unfortunately, we don't have a lot of time, but we're at the stage where we want to go into the questions and answers. So if there's anyone in the audience who has any additional questions to ask, please feel free to add it to the question and answer section. But for now, I think we'll start to go through the questions that we already have. Also, if you want to unmute and include any other questions, please feel free to do so. So as people add more questions, I just want to start to go through the ones that we have here. So there's one who's asking about government policy for informal providers in your country. Based on the timing, I believe this is Bangladesh. So this was when Dr. Mafuja was speaking. So I don't know if you could respond to that question on government policy for informal providers in your country.
Thank you. Yeah, a very relevant question, actually. So for informal, there are policies definitely, but in brief, what I want to mention that actually for informal providers, they cannot actually prescribe. They cannot prescribe, or they can only identify the symptomatics. For example, if you have a cough for a duration, then they can refer them for testing to a center where the recognized technician is there, and also the doctor can identify as the patient. But for the first level of care, actually they can refer. And they also, after diagnosis, they can monitor the treatment. It's not they're prescribing the treatment. The treatment already, the regimen provided by the doctors, and then it come to the community level, so that it's a longer duration, like 6 months of medicine, so that they can easily take the medicine from the next door informal provider. But he's not prescribing. He just have the list of medicine and he monitors whether he's taking his regular dose. So the policy, according to the policy, they cannot actually prescribe and do treatment in that way. Yeah, thank you.
All right, thank you, doctor. Then there's another question I think this is for the team from India, because this was when this question was posed. It says, were IPs empowered to suggest TB prescription if they were provided training? Shahina, who is the person who asked the question, if I'm asking it to the wrong person, please let us know. But I think I was addressed to the first speaker from India. So if you could respond to that.
Yeah, so in India, like informal providers, we have like almost five pathies, like we called it as Ayurveda, homeopathy, Siddha, Yoga, and Unani. So, and again, health is a state subject, so the policies varies from state to states. But there are different, definitely some policies that some informal providers like Ayurvedic or homeopathy, if they have some curriculum for allopathy, if they are trained in that curriculum, they are permitted to prescribe. But generally, what Bangladesh Mahfouz also have mentioned, generally they are referring for as a presumptive cases for diagnosis, and subsequently a specialist decides for the treatment regimen and they do it. But if they have a good formal training in allopathy medicine, so to some extent they are also allowed to prescribe.
Yeah. All right. Thank you. I think Dr. Saminu can testify to the fact that it's quite similar in Nigeria as well. We have different tiers of provision for private providers based on our PPM guidelines. So depending on what kind of provider it is, the kinds of services that you are able to offer is different. So we actually have it very, very clearly defined. This provider can provide this level of service. We have like 4 different tiers, and some of it would just be referral. Some of it would require both referral and then you can provide dot services. Some prescribe, some diagnose, but then it's really clear to sort of almost situate each type of provider to the types of services that you're allowed to offer. Poshan, your hand is up, so I assume you have a question.
Right. So I just got kicked out of the meeting room, so I can't open my video, but I just wanted to add something to in case of informal healthcare providers. So one of the things in case of informal healthcare providers is the lack of clarity in the policy. We all know that they exist in the community. We know that they need to be integrated. But then if you see WHO guidelines, if you see National TB Care guidelines, we have clear guidelines outlining how the formal private sector can be engaged, but we tend to ignore and overlook the fact that, which has resulted that there is no guideline how these providers can be engaged in TB care. I did my research for 5 years in the state of West Bengal. West Bengal is slightly different because in that state, the IPs are recognized and the government has initiated a 9-month state-level training program. So what happened is that with that recognition, now these providers are being engaged in different programs like vaccination, and there was a massive involvement of these IPs during COVID-19. So I would say the first step in case of informal provider is that bringing that clarity. If we want to engage our informal provider, what is the process? And it's not, now we have enough evidence to make some conclusion, to put some recommendations on the table. So that's one aspect I wanted to highlight broadly when it comes to engaging the informal providers. And in terms of treating patients with TB medications by informal healthcare providers, I did a research and where there were informal providers and providers from the formal health system. It was also done in West Bengal. And what we found was that IPs did not want to prescribe medication because their perspective was that this is a specialized field of care where untrained people should not be involved. So overall, it again comes back like how and where IPs should be engaged and the existing unclarity in the policy at a larger level. Thank you. I just wanted to add some of that.
Thanks, Poshan. Yeah, that adds some clarity. So Firdausi wants to ask the India team, the question is, can you tell us about TPT for contacts in the India program?
So you want me to talk on the TPT?
Either of you from India. The question is
Yeah,
for
carry on, Dr. Rajab.
Feel free to go ahead.
Yeah. So now TB preventive treatment in India, already it is being implemented for PLHIVs after ruling active TB disease. But now program have expanded it to all household contacts of pulmonary TB cases. And there we are systematically ruling out the active TB active TB disease among these household contacts of pulmonary TB cases. And that ruling out active TB case, it's a symptomatic, and then deciding whether this household contact is eligible for TPT or not. There are different strategies like to rule out whether TB infection is there. We have a option available currently as a TST or IGRA. But again, there are challenges for having availability of all those tests in the field. So these tests are also done in some places, or if it is not there, then chest X-ray is done. If chest X-ray is also not available, then we can, based on symptoms, contact is not having any symptoms, then they can be initiated on 6-month isoniazid TB preventive treatment. And also there is one more regimen approved, that is 3HP, that is 3-month weekly dose of 3HP, that is isoniazid and rifampicin, that is weekly dose for 12 weeks, that is 3 months. So these two regimens we are using currently in the program. So recently, the national level, there is a huge procurement of our 3HP, and that is going to be rolled now pan country. Previously, it was only 6 months isoniazid. Even for patients, household contacts of MDR TB cases, also there are guidelines, and those are also being used. But definitely these strategies needs to be more aggressively expanded so that we can have a strong preventive component in the country.
All right, thank you so much. So let me use this opportunity to thank you all for your presentations. They've been pretty amazing, and it's taught me a lot. And also thank you for the work that you do. Obviously, you're making a big difference in TB globally and in your country. So before I hand over to Joel, I just wanted to go round the panelists. If you have any just final words, do you have one takeaway that you want us to leave this webinar with? So I'll start with Dr. Saminu, because you haven't spoken a little bit. So Dr. Saminu, do you want to tell us just very, very briefly, 30 seconds or less, what's the main takeaway that you want us to remember about rural TB care?
Okay, well, thank you very much, Azi, and everyone else. Of course, we can't shy away from the fact that people reside in rural settings, in as much as the diagnostic tools and the skills for diagnosing people with TB and managing them are mostly in the urban centers. We still have to focus on those in the rural centers. From my presentation, you could see that many of our cases from the states we supported were from the rural place, communities. And of course, we could leverage on learnings like what TLM has done in northern Nigeria by using pseudo hubs, where we have 4, just as you mentioned, we have 4 different PPM schemes in Nigeria. The pseudo hub is not part of it per se, but it was just designed in such a way to accommodate these communities where we could utilize pattern medicine vendors that have some knowledge on healthcare and work in as TB workers in the public sector. So we could utilize these ones to ensure that TB diagnosis and management is accommodated for those in the rural sector. And all this is possible not just in Nigeria, but all across the world. Thank you.
Thank you, Dr. Saminu. Dr. Mafuja?
Thank you. Yeah, the takeaway is actually we are utilizing the network of the informal providers. Sometimes they are not acknowledged, like the community workers in the society, right? But they are really playing an important role. They're already there. They're already providing the services, but how to bring them closer to the TB net services is the thing. So we cannot ignore their presence, but rather if we should engage them with proper knowledge, proper message, TB related message, and then we can get very good support. And we can also support our patients with like a patient-centered care, through the patient-centered care.
All right, thank you so much. Shankar?
Yeah, and Joe, thank you. First of all, thank you for this opportunity. Second, so it's very important to engage all important stakeholders from the rural area, including private providers. And there are different challenges in rural areas compared to urban. But it's very interesting, and I think it's much more easier to eliminate TB from rural rurals, because of there are compact population, and kind of the intensive interventions, those need to be done. And definitely the national NTP, National TB Elimination Program, need to invest more in rural areas as well, and intensify their efforts to achieve those SDG targets. And I think Government of India is very much in line, and has similar initiatives for urban and rural areas as well. Thank you.
All right, thank you very much, everyone. Joel, can you round up for us? Yeah.
Yes, thank you, Azzy, and thank you everyone for, firstly, thank you panelists for taking the time to share your experience. It was really informative, and it was wonderful to hear the work that's being done in all your respective countries to engage these informal providers. So thank you for sharing that experience, and thank you, Azzy, for moderating the session and wonderful coordination. And thank you, Poshan, for also the introduction. And all the attendees, thank you so much for listening in. Or as I mentioned earlier, all the panelists today are members of the Learning Network, so you could visit, read about their profile on the Learning Network. I'm going to share a few links for you to join on the TBPPM Learning Network. I'm also going to quickly launch a poll to quickly get your feedback on today's webinar. So if you could stay back and answer these questions. So the question is going to be up for a couple of minutes, and we will end the webinar in 2 minutes. If you've answered the question, feel free to, you can leave the webinar, and keep an eye out on the TBPPM Learning Network for upcoming webinars. We will also be planning a webinar on this topic on informal providers again in June to July of this year. So keep an eye out for that announcement. And if you haven't registered for our TBPPM Summer Institute course offered by the McGill Summer Institute, please do register yourself for that McGill Summer Institute course, and where you could gain more knowledge about private sector engagement.
Thank you. Thank you all. Bye.
Thanks, everyone. Bye-bye.
Bye-bye. Thank you.
Bye-bye. Thank you.
Bye.